All right, welcome back. We're going to do a quick review of the knee complex palpation. Then I'll post up some other videos of the knee adjustments before we move on to new stuff. So we'll start with the tibiofemoral joint. Long axis distraction of this joint. We brought the leg out to the side here. We contacted that distal femur. So as I contact that distal femur, I apply a pressure that is I to S with that contact here, and then I use that pressure, I use that as an anchor to pull my legs. And so what I'm doing here is I'm trying to decompress that knee by contacting the distal femur with my hands and pulling S to I with my legs. So I'm anchoring and pulling. Next was an A to P and P to A palpation. So with a bent knee here, we palpated for that tibial tuberosity, and then we challenged A to P. We said that we could sit on our patient's foot and challenge. We could kneel if we're concerned about that foot sliding or slipping. And then P to A was the same way, was a pull here where a thumb contact over those that tibial plateau allows us to feel if those the ligaments here that we're assessing are lax in any way. We then did internal and external rotation. So we brought our patient's knee up here, palpated over that tibial tuberosity, and then used this contact down here at the ankle and induced internal and external rotation. And we used that tibial tuberosity as a guide to show us if we had enough internal and external rotation. We said that we needed a 40-degree arc here. We did some exercises and some assessments in class where we assessed this actively while our patient was seated. Next is lateral to medial and medial to lateral. So remember, we had our patient's leg out here, and then we wrap our arm around and then grasp here so that I can challenge medial to lateral or lateral to medial here. The other way that we said you could do this was with a leg stabilization here, palpating on either side of that knee, and then challenging medial to lateral and lateral to medial. Remember, when doing this palpation though, that this knee, if it is completely locked, if it is completely straight, I'm not going to feel much motion lateral to medial or medial to lateral here. I do need to have a little bit of a bend in that knee. Not a lot, but a little bit of a bend in that knee so that I can feel that medial to lateral, lateral to medial movement that exists there. Next, we assess the patella. So in assessing the patella, we used kind of this hand grip, and we dropped our hands over that patella. We did an S to I challenge, an I to S challenge, and then medial to lateral and lateral to medial. The last 4 palps were for the tibiofibular joint. And so in assessing that, we had a bent knee, and then we palpated over that proximal fibula, challenging A to P and P to A. Remember that the soleus lives in this area, and that's really prone to muscle hypertonicities, etc. So our palpation in this area, we need to be communicating with our patient, making sure that they're not in any discomfort as we're challenging P to A. And then we did an I to S and S to I, and we said we could palpate over that fibular head here, and then I could do an inversion and eversion of the foot and feel for that fibula to shift, I to S and S to I. So that is a quick review of the palpation of the knee complex.